Hello everyone. Today we'll be discussing a very important topic, a fairly common clinical lesion, that is follicular lymphoma, and we'll discuss various high-yield points that are very much relevant and very important for different exam point of view. So please subscribe to the channel and give your valuable feedback. So what is follicular lymphoma? Follicular lymphoma is a kind of a very common indolent non-Hodgkin's lymphoma, which is very commonly seen in United States, European countries. That is very common in certain parts of the world, but it is prevalent throughout the world as well. And it is derived from B cells. The tumor cells form follicles. They form predominant follicles. That's why the nomenclature follicular lymphoma is being derived. Because of the predominant follicles, they are amenable to get confused and mistaken for follicular hyperplasia of lymph nodes that is seen in many of the reactive conditions. So there are certain characteristic genetical features. The most important thing that is often asked on very commonly there in your vignettes is T14-18 translocation. So don't forget to remember that. And this chromosome 14 has immunoglobulin heavy chain gene expression, and chromosome 18 accounts for BCL2 expression. So the translocation of the genetic material between chromosome 14 and 18 leads to overexpression of anti-apoptotic genes, that is BCL2. So BCL2 overexpression takes place, and this BCL2 overexpression leads to loss of apoptotic cells in the follicles or the germinal centers of the follicular lymphoma. So you will not get apoptotic cells in the follicular lymphoma affected follicles, whereas the reactive follicles, the germinal centers, you will have lots of apoptotic cells. So that is the cardinal feature, cardinal difference between follicular lymphoma versus follicular hyperplasia. So inhibition of apoptosis leads to longer survival of the cells. And the KMT2 gene mutation has also been found in majority of the studies. In majority of the cases, this gene has been implicated, and this gene accounts for histone pattern. So this gene mutation is being relevant in most of the cases of follicular lymphoma. Coming to the immunophenotypic staining, it will be CD19, CD20, the B cell marker positivity, BCL6, the germinal center marker will be positive, and the anti-apoptotic gene proliferation and the resultant marker, the BCL2 protein, will be markedly overexpressed. That is the characteristic clinching feature in the favor of follicular lymphoma. And to differentiate it from other lymphomas like chronic lymphocytic lymphoma, mantle cell lymphoma, here there will be absence of CD5. The CD5 staining, aberrant staining of T cell marker, that will be absent over here. So coming to the clinical features and the treatment, it usually occurs in middle-aged individuals, more commonly seen in middle age and beyond that, and with males and females showing equal predilection and equal preponderance in both males and females. And the common mode of clinical presentation is that of painless generalized lymphadenopathy. So please pay attention to this. This will be always marked in your vignettes. Painless generalized lymphadenopathy, that is a fairly sensitive clinical feature of follicular lymphoma. And you must know that the bone marrow involvement is pretty common. It is seen in majority of the cases of follicular lymphoma. So that can lead to leukemic transformation. Fairly indolent but not amenable to chemotherapy, because here there are no neoplastic cell involvement. There is no neoplastic cell proliferation, but rather than that, the normal cells, because of the loss of apoptosis, the germinal center cells, they survive for a longer period of time. So so any kind of a chemotherapy will not work because there are no neoplastic cells. It's just a lymphoma caused by the longer survival of the cells. However, many of the symptomatic patients, they are treated with anti-CD20, BTK inhibitors and BCL2 inhibitors are tried in them to give palliation and affect their survival and give them longer survival. So it is clinically, it is incurable as such, with median survival of 7 to 9 years. So they are incurable. They as such, they are not amenable be treated with any of the chemotherapy or any of these anti-CD20 and anti-B cell marker therapies. And half of these patients, 30 to 50% of these patients, they in turn progress to fairly aggressive lymphoma, that is diffuse large B cell lymphoma. So DLBCL transformation is also common, that also you must remember. So DLBCL transformation is also seen. So in many of the DLBCL cases, we get even BCL2 expression is also seen in DLBCL. So that corresponds to follicular lymphoma that has transformed to DLBCL. So BCL2 overexpression may still be seen in cases of diffuse large B cell lymphoma. So coming to the morphology, so the lymph nodes are replaced by neoplastic cells that are arranged predominantly in follicles or nodules, or both nodular and diffuse form. So lymph nodes lymph nodes and other lymphoid organs. They are having predominant for follicular or nodular arrangement, and sometimes both nodular and diffuse, both mixed kind of arrangement may be seen. So the most common differential diagnosis is the follicular pattern of reactive hyperplasia that is seen in conjunction with various reactive or inflammatory or infective conditions. So two types of cells are very predominant: small cleave cells with scant cytoplasm that are referred to as centrocytes, and large cells with open chromatin, several nucleoli, and a moderate amount of cytoplasm. So these large cells are known as centroblasts. So depending upon the relative proportion of centrocytes and centroblasts, there is a grading system that divides follicular lymphoma into grade 1, grade 2, grade 3. That basically speaks about the number of centroblasts per high power field. So the neoplastic cells, as we discussed earlier, BCL2 oncoprotein is overexpressed due to 14-18 translocation. Bone marrow involvement is seen in as much as 80 to 90% of the cases, and paratrabecular lymphoid aggregates is observed in bone marrow biopsy. Splenic white pulps and even hepatic portal triads may also be involved in follicular lymphoma involvement. So you can see the nodular affliction of the spleen. Multiple nodules are seen over here. That is a classical feature of follicular lymphoma spleen. And here you can see the follicular aggregates or the nodular aggregates, which is very commonly observed in the low power and even in the low powers of low power of histopathology of the follicular lymphoma. This nodular pattern is very commonly observed. Coming to the high power view, here you can see the very large cells, open chromatin pattern, and a single nucleoli. This is centroblast. And here you can see the centrocytes. Centrocytes, you can see the cleave cells, the cleave nuclear membrane, and multiple nucleoli, and these smaller cells are known as centrocytes. So the larger cells with open chromatin and non-cleaved pattern is known as centroblast, and the smaller cells with cleaved nuclei and there is a multiple nucleoli, these smaller cells are known as centrocytes. Now let's discuss an MCQ to end up the presentation. A 66-year-old man has noted an increasing number and size of lumps over his body in the past 5 months. On examination, there is a form non-tender inguinal, axillary, and cervical lymphadenopathy. So you can note that there is generalized lymphadenopathy. More than 2 group of lymph nodes are involved over here. Biopsy specimen of the cervical node shows a histological pattern of nodular aggregates of small cleaved lymphoid cells and larger with open nuclear chromatin pattern, several nucleoli, and a moderate amount of cytoplasm. Bone marrow biopsy shows lymphoid aggregate with surface immunoglobulin that are CD10, CD5 positive, and CD5 negativity. And karyotyping of these lymphoid cells indicate the T14-18 translocation. So what is the most likely diagnosis? So you can see all features of follicular lymphoma are seen over here, and generalized lymphadenopathy, a bit older age group affliction, and there is CD10 positivity, CD5 negativity that distinguishes from mantle cell lymphoma, chronic lymphocytic leukemia, and also there is a characteristic 14-18 translocation. So and also there is we are getting the small cleave cells and the larger cells, so centrocytes and centroblast. So all the features are in keeping with the diagnosis of follicular lymphoma. So follicular lymphoma is the answer over here. So hope you learned the salient features of a very common clinical follicular lymphoma, which is exceeded only by diffuse large B cell lymphoma in the frequency. So yeah, and you learned how to answer various questions. You grabbed various important points of follicular lymphoma. So please remember to keep on watching this particular video to grab the important aspect. And don't forget to subscribe the channel. And also, if you like the video, please please put a like on the video, and also give your appropriate feedback. So see you all very soon in the next presentation.